All right, welcome everybody. Hello. Very excited today to have the final presentations of the scholarly inquiry class today. Um, Welcome everybody in the lab as well as our online guests. We are streaming, we are live in case anybody's wondering. And thank you everyone for joining us for this year's presentation of our medicine and design student research. We're really excited for everyone to see what you guys have been working on for the past 2 years. But before we get going, I just do a little bit of introduction. So we are here today for folks who have never been to the Health Design Lab. We're here in the Health Design Lab today, coming to you live. The Health Design Lab is both a space and let me just forget to share screen. The Health Design Lab is both a space and a series of programs here at Jefferson. We exist to create an ecosystem where design and medicine collide to exemplify the power of design to make our world a healthier place. So we have areas of expertise in a number of different places, but 4 particular buckets. Core to our mission is what we're here to do today, and that is teaching health design methods to future physicians. But we also teach these things to professionals from around the world. It was really exciting this year that along with supporting some initiatives here at Jefferson, we also had the opportunity to travel to both Ireland and Latvia to provide education and support health systems who see the value of good design and good healthcare. We also continue to work in bringing our creative approach to mobile health outreach programs, bringing care to where people live, work, and play. We're really excited about some upcoming stuff that's going to be happening with our colleagues at Sidney Kimmel Cancer Center to grow our outreach efforts here in Philadelphia. And I also want to bring attention to the work that Bon and Morgan are now doing with the Advanced Research Projects Agency for Healthcare, innovating in the mobile healthcare space with the Paradigm program that was just released. If you guys haven't read that yet, check it out. It's really amazing, incredible work, and it's going to be really cool to see where it goes. Our medical device development continues to happen here with students in our MedTech, our Jeff Saul's MedTech program, as well as numerous projects that we enable with internal innovators across Jefferson and beyond. And if you missed the 2023 Jeff Saul's pitches, you can watch them at healthdesignlab.com. They were really great. And lastly, we continue to lead in medical 3D printing, and we have some really great publications come out this year that we're really proud of. And we continue to have ongoing clinical research. And I even wanted to announce that we were awarded an innovation grant that was championed by our Health Design and Research Fellows from the Radiological Society of North America. So that's a really cool opportunity that'll turn into a really cool presentation next year at RSNA. Now, the thing that we're all here to talk about, to learn about today is the Scholarly Inquiry Design track at Sidney Kimmel Medical College. Now, what is that? So the design track at SKMC is powered by the Health Design Lab, and it's a groundbreaking 4-year curricular program where medical students conduct research at the intersection of health and design while learning to be creative leaders who are prepared to tackle tomorrow's ever-changing healthcare landscape. And through a series of engagements in the Health Design Lab, students learn and apply health design thinking methods to identify a real-world healthcare challenge and design solutions so that they can have a real impact on people's lives. And the presentations that will be given today are the presentations from their hard work over 2 years to take us to this point. Now, of course, I have to thank a lot of people who are instrumental to making this program run. First and foremost is the woman to my left, Mary Ellen Daly, who is the kind of beating heart of the lab and helps us, helps run this program and keep it all organized, as well as keep me organized and keep the lab operating every day. I want to thank our SI Design mentors and faculty, Jeff Hayden, Kelly Kem, Bango Okusanya, Matt Krasinski, Morgan Hutchinson, and Bom Koo. Especially, I want to thank our HDL research fellows, Sarah Belko and Rachel Monane, who are absolutely essential to everything that we do down here. Thank you so much to the SKMC Scholarly Inquiry team. There is a lot of work behind the scenes to making this program work in one of the most challenging curriculums that exists at medical school, and somehow we're able to find at least some time to provide an opportunity for a unique experience for our medical students, and that wouldn't happen without a really strong leadership team, both from Scholarly Inquiry and then SKMC leadership at large. And then, of course, the thank you goes out to our clinical staff and the collaborators. Each of our student teams work with collaborators outside of, our small group here so that they can validate things, they can learn things and go to where the problems are so that they can be better problem solvers by through that collaboration. And we couldn't do it without those folks. So without further ado, here's our order of presentation today. So we've got 6 teams. Teams have 15 minutes to present, as well as a 5-minute Q&A period. For the folks online, you're welcome to use the Q&A feature in the Zoom webinar, and that's being monitored by Sarah over here, and she'll relay any questions to the audience. And that's it. So I can't wait to see what everybody has in store and share with everybody online. So I'm going to set up the first team. That's going to be team 1. You're welcome to head on up here as I get your slides. Woo! It's always the fun part. Okay, there's that, and there is this. That. All right, let me just reshare. And the floor is yours. Here you go.
Hello there, everyone. Thank you so much for being here today. My name is Tyler Raddick, and our project is Concealed LVAD Garment for Improved Patient Satisfaction. Before we begin, we just wanted to introduce our team. My name is Tyler, like I said.
My name's Daniel.
My name's Meredith.
And my name's Deanna. So to get us started, we'll start with the idea that we came up with from my patient Bill. So some of you may know I'm an inpatient physical therapist at Penn, where I had the privilege of working with patients with end-stage heart failure. Bill was one of my patients. He was a 74-year-old guy who did not qualify for a heart transplant and ultimately needed a VAD implantation. So when we say VAD, or VAD, that stands for ventricular assist device. So basically this helps the heart pump more efficiently because their heart's failing. So if you take a look at the bottom picture, you can see that the internal component is actually a motor that goes to the ventricle that provides the power to help the heart eject blood. Then that component has a drive line that leaves the internal component, exits via the abdomen, and attaches to a part called the controller. So that's like a little box that basically shows the parameters of the VAD. And lastly, there's 2 batteries. So these are about 8 inches tall. And these are what batteries do, provide the power for it. So those are, there's 3 components total that are external that these patients need to have with them 24/7. So that would be the controller and the 2 batteries. So bringing us back to Bill, the options that they give you, which we'll show in the next slide, are either a bag or a vest. And Bill, like most patients, didn't appreciate these. They were external and they were really uncomfortable. So he ultimately decided to ask his wife who could sew to sew this shirt for him, because to buy these shirts elsewhere costs $100. So as you can see in the picture, that's with me when I visited him at his home. In the front, like the kangaroo pouch component is basically where the controller goes. And then on the side is where the 2 batteries go. So he said he had wanted something that was concealable. He didn't want people to see that he had a VAD on him. And he also wanted something affordable. And that's really where we got the idea for this project.
So Deanna alluded to a couple of the current designs that are available for patients. As you can see over in the top, I guess, left there, we have the 2 that come basically standard with any LVAD. We have the vest on the top, and then we have the bag slightly underneath. The issue is like Deanna said, the vest can be very restrictive And the bag, which is by far the most used product that patients seem to be walking around with when they have a bag, is very heavy because it concentrates all the weight in one spot. And especially for smaller patients, this about 5 to 7 pounds hanging off the front of you can be rather uncomfortable throughout the entire course of the day. Now, that leads patients to try other options. And so they may try a different style of vest, which you can see in the middle here. And while, yeah, it might work well, it's $120 for essentially a few swatches of mesh. Some patients might decide, hey, it's a little heavy, I want to move it to my back. And so they will buy a backpack. And it's a $140 backpack for essentially what is just a couple straps. And a lot of times the surgeons are not the biggest fans of these solutions because they have an increased tendency to pull on the actual line going to the pump. And there's an increased risk of either fraying of the line or increase in infection. For the more fashion oriented, we have the ladies deluxe vest and matching bag. And while these are a bit more robust options in terms of their materials, they are definitely a choice to say the least. And the issue is that a lot of patients, this may not be the patient's style. And so patients might struggle if they just have to wear this every day or just walk around with a bag. So this leads a lot of patients to some type of undergarment type option. And a lot of patients opt for, as Deanna said, a kangaroo style patch, as you can see here and in the bottom left. And because of that, they're great options because they keep everything concealed, they hold everything where it needs to go. But after talking with a lot of patients, we realized that a lot of them are not durable in the slightest, especially when a patient is wearing these every day and might have to opt for $100 options and may have to buy more of them over time. So there's really not a great solution. And so what patients have a general tendency to do is go DIY. And they'll take what we see right here, which is a football girdle, cut out all the pads in it, and then replace that with the batteries and the controller that traditionally come with an LVAD. And this type of design is actually what was a major kind of driving force in where we went with our design. So Dan, what are some of the other problems patients face?
Yeah, so as you can imagine, there are significant psychological and financial problems and burdens that come with wearing an LVAD that often gets overlooked. So psychologically, an average person with an LVAD has below average well-being, below average self-body image, and a higher rate of anxiety and depression. And financially, it was $175K just to implant an LVAD. And most patients actually end up having to carry that LVAD for the rest of their lives. So for lifetime management, it was actually around $730K. So on top of that, you have the garment, which continuously adds to the financial burden for patients.
So the objectives of this project are to, 1, create an affordable LVAD garment in a limited and overpriced market, improve comfort and style for these patients, use consumer feedback to refine and enhance our design, and ultimately to improve the quality of life for this patient population. So our problem statement, just to recap everything we've talked about so far, how might we create an affordable garment designed to hold a ventricular assist device that is able to be concealed underneath patient clothing while still maximizing patient comfort and usability?
So after talking with the LVAD clinic and some patients in the LVAD clinic and just doing some research, we came up with 6 major components that we want to target in our prototype design. So number 1 was cost. We already stressed this enough, $730K for lifetime management and around $100 for each garment. So we want to lower that cost so that it's more accessible for everyone. Another big one was driveline infection. We talked about how that driveline comes from the internal body part to outside the abdomen. So that area where excess body is prone to infection. So we wanted to create something that will minimize the infection by better cord management and less moving. And size adjustability is another big factor in our prototype because patients with an LVAD tend to have a larger body habitus. So patients often complained of the options not being too robust, and whatever option they had, it was pretty tight on them. So we want to make something that was more flexible, and so that patients weren't feeling like they were getting choked by wearing an LVAD garment. Another big one was a weight distribution, especially for patients with the t-shirt option. We looked at Bill's kangaroo pouch. One big problem with those options was that because all the batteries and all the components were in the front, patients were often getting bent down, and it was really heavy. And after a whole day, it was really a burden for them. So we want to have better weight distribution, so that on either side of the body, so patients weren't getting dragged down all the time. Another big factor that was identified was heat distribution. So those batteries, after a whole day of working, it really heats up, and especially in humid summer months, patients really complained that this was getting really warm and really annoying to deal with. So we want to have options to either cool down the machine or have at least like a big insulation component so that people won't have to deal with the heat as much. And probably one of the most important parts of our design is the aesthetics, right? So I want to just give you two examples, patient examples that I think are really important. One patient just went to his LVAD clinic, got his regular checkup, came outside and got pulled over by the police because they thought he was strapped to a bomb. So obviously the patient was mortified by this whole experience, was self-conscious, and was one of the worst experiences. So he wanted something that was more concealable, more discreet. Another really important example was a woman. She loved going to church every Sunday. She would love wearing dresses. And after her LVAD, she just couldn't wear a dress anymore because of all the wires. And all she really wanted was just to go to church again, hang out with her friends, and just be able to wear that dress again. So for those reasons, we just wanted to create something that was a little more discreet, so that patients can just be themselves, be able to express themselves, and it will help their mental health overall.
Okay, so here are pictures of our bag, but I am also wearing the bag. So as Dan mentioned, you can wear a dress with this, and I'm going to very delicately lift up my dress so everyone can see the VAD. So obviously I don't actually have a VAD implanted in my heart, but I have the components to it. So yes, thank you. So first, this is the controller. So this is a component that actually connects to the VAD and displays the power settings, and I can take that out for you. And then put it back in. And then these are the two batteries. So as you can see, they're pretty robust batteries, and you need to have two of them at all times. So these are on the sides here. And then we have padding here that provides like heat distribution. So as you can see, this isn't providing any of the problems that we've had with the previous shirts and bags, right? I'm not being pulled forward by a bag. I can still pretty much cover up with a dress, and a lot of people haven't noticed that I've been wearing this. And I don't have anything on my shirt. So this is really like kind of our main prototype. Obviously we have to play around with like different stylings and things for patients, but this seems to be like a good weight distribution and then has the concealability.
So this is really like a 20,000-foot view of our project right now. So we already identified the problem, went and saw the patients, and came up with a prototype. So we really need a tangible, quantitative, qualitative measurement of what the patients saw, what their satisfaction and quality of life was with that prototype. So we decided to come up with a survey and just distribute it to patients to see what their thoughts were on our product. So we needed an IRB approval to get this whole started, which we obtained in October. And now we're just in the process of distributing our survey and prototype. We're actually going into clinic tomorrow to show our prototype and talk to patients. So it's an exciting time for us.
So just a little bit more about why we decided to do a survey. So as Dan sort of mentioned, the purpose of creating and distributing a survey is to gather data from a larger population of LVAD patients and hopefully make our project a little bit more generalizable to a bigger population. The goal of the survey is to tease out what truly matters to patients in a standardized way in regards to how they choose to wear their LVAD and what factors are most important to them when selecting what garment to wear. Obviously, we hope that the results from the survey will be robust enough to help inform our subsequent prototypes as we go forward. So some of the things that are asked on the survey are things like patient sizing and demographics. As we said, this population, from what we've seen, tend to have a slightly larger body habitus. So this is an important aspect of the survey. We also wanted to definitely ask about what patients are willing to pay for a garment, the number of garments that they need to own, and their garment preferences, and as well as what factors are most important to them, as I already mentioned. We are, as Dan mentioned as well, we are working with LVAD coordinators in Center City to get this survey distributed to patients, hopefully very soon.
So just to wrap it up, our next step, as I mentioned, is to go into the VAD clinic tomorrow and get more feedback from patients, distribute the survey and start collecting data. And then we did submit for a patent, so that we will get feedback on that and hopefully be able to tweak it so we have a permanent patent. And then naturally, we need to continue to revamp our prototype, make sure that most patients feel comfortable with it. The biggest challenges we're going to face are really just raising funds for this, having multiple iterations, multiple sizes, different materials we've been playing around with. And then also just like bathrooming. So this hasn't really been an issue with other devices if you have a bag or a shirt, but naturally to pull down your pants to go to the bathroom can be a hindrance for some patients. So that will be something that we're going to look into more and see how patients feel about that.
So in closing, we just wanted to thank first all the patients in the LVAD clinic that we interacted with, and in addition to that, Dr. Okusanya, who has been a great mentor to us so far. And then additionally, all the LVAD clinics and coordinators that we worked with, a special shout out to Tim Robbins, who's been really helpful, especially in the beginning with this project. Obviously, Deanna's patient, Bill, the Health Design Lab, and then Rob and Mary Ellen, of course. So with that, we invite any questions you all may have.
All right, that's awesome. If you have any questions, well, while you guys think about questions, I have a question. Really great job kind of knitting together the aspects of design, research, right? And you're thinking about commercialization. What's like a best case scenario for you when you're like 2 years from now, you're finishing up med school? Where do you want to see this project?
Yeah, so I think at that point, I think the real goal is to really finalize the design probably over the next year or so, and then hopefully get some level of patent out of this project, because we would really like to see this eventually go to commercial, if it's possible, to work with different companies and different things like that to have potentially have this go to market. So that's definitely the goal. Probably in the next 4 years, some level of patenting or something like that would definitely be the goal.
Mm-hmm. And then I know you guys have that great slide on all the options and how limited they are. I'm just going to stop the sharing, that way you can see us better. What was like the most surprising thing as you dove into this world? I know it's pretty unknown to a lot of people who haven't experienced it. So what like really surprised you as you begin to dive into the life of somebody who experiences the challenges around an LVAD?
I think something that was very impactful was the amount of people who are DIYing their own solution. There's tons of online forums and sort of support groups that LVAD patients tend to flock to. And a huge topic on these forums are patients, finding different creative solutions for wearing their LVAD. And just, it was shocking how expensive these things were. And because, patients need multiple of these, you're talking, it's every single day, all the time. So you're talking at least a week's worth of garments. So I think I was just surprised, and I think we were all surprised about how limited the market was in general.
And I think just also seeing that even at the hospital, like these options that patients prefer are not provided. It's really just the bag option that's given to patients. So a lot of these VAD coordinators, and being a PT, I would go in with the VAD coordinator. They would say, here's what we're giving you, but we recommend this other thing. And by the way, it costs $100. So that always like surprised me that it hasn't been integrated to the point where it's just like a part of standard patient care.
All right, any other questions in the room? Go ahead.
So I know you obviously are planning to do a survey next, and one of the things you're working to understand is like sizing. Have you thought about that at all? Like how you would accommodate different heights, and then also like, patients losing, gaining weight. Do you envision this being like adjustable, or just like different stock sizes that they would purchase?
We'll talk about that. So, yes, we have thought about this. One thing, of course, is just the material itself, like making sure it's a stretchy material, but we know that patients can have bigger sort of weight changes than just like a stretchy material could accommodate for. One thing we were thinking of, which actually goes along with sort of the bathrooming issue, is they make a lot of like adaptive briefs now that have like button closures, like sort of like bra hooks, like hook and eye closures. So potentially having like different settings, different staging to make a waistband more adjustable. And of course, also having like, as in any sort of regular clothing, a small, medium, large situation eventually, I think is where we're headed towards sizing and adjustability.
Question online?
We have a We have this is a very interesting project. Thank you so much. Are you thinking maybe of communicating your experiences via an article? Or perhaps since there are so many other diseases that require garments that are designed with a specific condition in mind.
So just so in case the folks online couldn't hear Sarah, the question from the audience was, what type of kind of publication or output would you like to see? Or are you planning on utilizing to make sure what you've learned here gets out to the world?
Yeah, I think the main going forward with like potentially having an article or publication will come out of our survey. There's not a lot of studies that have been done on LVAD garments. There are a fair amount of studies, as Dan was mentioning, about sort of psychosocial health in LVAD patients, but not a lot just sort of going into what contributes to those factors. And I think the garment, as we've seen, is sort of a big deal for these patient populations. So we're hoping we're going to get standardized data from the survey that we could potentially publish in an article going forward.
Sure.
Just had a question about the heat distribution. Where you could just talk a little bit more about that. Did you take the existing solution from the market and just integrate it into the garment? Or was it more of like a de novo approach, like trying to figure out like optimal heat channel pathways or something like that?
The actual solution to that came out of, I think, just us playing around with it a little bit. So what we used to make that was actually a football girdle. We bought a football girdle and then used the pads in that. And typically patients just completely remove them. But we noticed that, what happened was I forgot to take them out of the pockets, and then we put them in one. And we realized it was a really great option because it's already utilizing something that we had, but it was a really great option because not only does it block the heat from either the battery going into the patient or the patient going into the battery, but it also provides a little bit of cushion because there are some sharp angles to that. So it was a bit of trial and error once we realized that, but a little bit of it was we got a little lucky with just a direction we were thinking. And then now I think when we go to modify it a little bit more, changing different thicknesses of the padding, maybe a different material is definitely a way to go with that going forward.
Thank you.
All right, thank you very much. All right, we're going to bring up the next team in just a moment.
I inject. So much problem.
Where you stay right now. Why was it that way?
Can you just hit refresh on that?
Yeah. All right, almost there, almost there. Bingo. All right, you're sharing and you're good to go.
Hello, everyone. My name is Katie. This is Alicia, Ari, and Sarav, and we're all second-year medical students. And our project is designing to improve manual wheelchair user experience. So when we started this project, we knew we wanted to work in this space of people's ability to move and exist in the world. And so we started by talking to different wheelchair users, both motorized wheelchair users and manual wheelchair users. And so to exemplify sort of our process of inspiration, I want you guys to meet Sarah. Sarah is one of the wheelchair users we interviewed when we began this project. She's paraplegic, meaning she's paralyzed from the waist down, and typically she gets around in the world through use of a motorized wheelchair. However, when we talked to Sarah, we found out that a lot of time is spent where she doesn't have access to her motorized wheelchair because it's in the shop either being repaired or undergoing some sort of routine maintenance. And for weeks and sometimes even months at a time, she can be without access to this and instead has to rely on her backup manual wheelchair.
And during these periods, she talked about how it's really exhausting to have to use her manual wheelchair. And as a result, she doesn't engage in her life in the same way that she would if she had her motorized chair, because she just doesn't have the same energy throughout the day. So to try to think about it as a room full of people who ambulate with our legs, I like to ask, how many people here have ever gone jogging on the beach? Great, a lot of you can relate to that experience. Think about how difficult it is to jog on the beach compared to walk on flat land, and think about how much extra energy it takes to maneuver yourself that way. That's sort of the comparison to how it feels to have to expend energy to move throughout the world using a manual wheelchair.
Yeah, so to put some numbers into this, Sarah is one of the 5.5 million wheelchair users in the United States, most of whom use a wheelchair that we probably have all seen walking outside or in public places called a hand rim wheelchair. So these are great that they're low cost and really low maintenance, but they present a lot of issues, like Katie was saying, with energy conservation. So to put this into numbers, it's estimated that the gross mechanical efficiency, which is essentially the ratio of the energy that you're inputting into the device to the amount of energy you're outputting, is only 3 to 12% for a manual wheelchair, which for walking is about 20%. So you're losing about half of your energy to operate a manual wheelchair compared to a walking individual. It's also estimated that about 42 to 64% of manual wheelchair users experience some form of upper extremity pain due to the poor biomechanical design of these wheelchairs, which can present in a lot of different forms, but for example, like shoulder bursitis or rotator cuff injuries. So the best alternative for this currently in market are your lever propulsion mechanisms, and that is shown to have an increase of 33% in the gross mechanical efficiency, as well as an improved ergonomic design that's eliminated a lot of those upper extremity injuries we've seen with manual hand rim wheelchairs. But the problems are that they're very limited in availability, making them difficult to find in the market and also very expensive. They can range from anywhere of a couple $1,000s in comparison to a hand rim, which is only a couple $100s.
So when we were investigating how much better it seems to be that lever drive wheelchairs are for the user, we were curious why they aren't more popular compared to the push rim style wheelchairs. And what we found is, like Alicia said, they're very expensive. They also have some other limitations associated with them. So one type of lever drive wheelchair you can think of on the left here is this jack drive style. And you can see the levers are attached to the chair frame itself towards the front of the chair. This unfortunately adds extra bulk that decreases maneuverability for the wheelchair user and also makes it more difficult for them to transfer in and out of their wheelchair. It also is quite costly, costing $4,000, which is really on par with a motorized wheelchair. And if someone had that amount they were able to get covered or spend themselves, then they would likely choose the motorized chair compared to a manual wheelchair, which is on the order of about $400. This also, if someone wanted to get this style chair, they would have to replace their entire wheelchair. Other options on the market are like this widget style in the center, and that can be retrofitted to an existing chair frame. However, you're required to purchase this integrated wheel and lever system, which costs about $5,000, again, prohibitively expensive, and must be sized appropriately for your existing frame. So if you have a frame that isn't compatible, you would have to purchase a new frame in order to make it work. And generally, insurance companies only cover the replacement of a wheelchair once every 5 years. The third option was kind of the closest to our inspirational jumping off point is this new drive system, which can be retrofitted to existing wheels and chairs of certain sizes. And for this method, you actually attach the lever drive mechanism to the wheel frame itself, which has the added benefit of you can use whatever existing chair you have. However, the limitations with this are that it still has to be sized appropriately for the chair you have. You still may not have a compatible model. It can add bulk to the sides of the wheelchair, which makes it more difficult to maneuver. And again, it is still prohibitively expensive. So this led to our creation of our How Might We statement. When thinking about all of these issues, we decided to ask, how might we improve the experience of using manual wheelchairs by designing an affordable lever propulsion mechanism that can be applied to an existing push rim wheelchair? That is our goal.
Okay, so going into the methods a little bit, so we basically started off with conducting some background research, looking at what's at the market, that we kind of talked about with Katie here, and some patent research to see what the solution space looks like right now. We also involved some stakeholders, such as physicians, occupational therapists, physical therapists, and various wheelchair users themselves, with their partnership with McGee Rehabilitation Hospital. And then basically throughout this whole process, we've been iteratively creating designs based on that feedback we've been receiving. And so that helped us culminate basically our design specifications that we wanted to optimize for our own design. So some features that we thought were important was that it should be a non-bulky and minimize the width as much as possible, and ultimately should not interfere with transfer at all. It should be able to be used and installed by the manual wheelchair users themselves, so as not to involve another individual if perhaps they live alone or can't depend on someone else to help them. And it can ideally be purchased without specialized vendors. Hopefully we could have accessed in like public or local shops, and then also obviously cost consciousness.
So the implications we've come across during this process of prototyping was that this prototype could be a medium between a fully manual versus a fully motorized wheelchair. And it could be something that helps people when either their electric wheelchair is being worked on, or if they're finding they need more mechanical advantage out of their manual wheelchair. And so we found also that 3D printing was a good option for us to go through this prototype process, and also for future customers, they could possibly like download our design, 3D print, and customize their own design at home. So we came up through this process with 4 distinct design iterations to improve mechanical advantage. This was kind of the timeline of where we started. We started with that new drive inspired lever mechanism there on the left in April of 2023. And then we switched to a more pulley mounted mechanism, some modification of the pulley mounted mechanism in July, so that there was a better positioning for hand grips. And then we came back to this fully lever option, which is where our design is at today.
Now, we'd like to show you some of the concepts and some of the animations we have. So the first part that I wanted to address is we wanted to make sure that our mechanism is easy for people to modularly install. So it's a little animation. So it just goes on like that, as a little locking mechanism. You can put on all those arms there, and then the lever just pops on. You can take it off just as easily. And it's just a 2-step, kind of like 3-step installation process there. Just let it play one more time if you wanted to hear real quick. And we also had a kind of like a working, like minimal viable product kind of prototype as well. Definitely a little different in terms of build quality. But at least we were able to show that the physical concept still holds. There's some shortcomings with this specific prototype. For example, you might see that my arms are moving a lot versus how much the wheel is moving. But we have some plans in terms of adding some gearing to increase that kind of like the ratio of speed input to output. So just to go through just some of the obstacles that we've had so far, we don't necessarily have formal experience in this sort of field. We're not engineers, we're not welders. Prototyping itself, making that physical model took a lot of time, a lot of planning, getting all those materials and everything. Also, there's a lot of IP that already exists, which makes it a little bit difficult to try to parse through everything and figure out what's actually novel. But there's also not that many products compared to how many patents are already there, which is a little interesting. And just in terms of the practical standpoint, prototyping, obviously buying materials and tools that takes up some funds. So that's a little bit of it slows down our progress a little bit, but we made it through. In terms of future directions, like I mentioned, we'd like to add some gearing to balance the speed and the torque. Obviously, having the larger or the longer lever arm gives you more torque. So if you have more of a hill, you might have more advantage that way. But potentially if our mechanism had a way of switching the gear ratios like you might on a mountain bike, that might let you, if you're going on a flat road, get more speed instead. Another direction is machining or 3D printing. Obviously, our physical prototype is made out of wood, so it's not the most durable, and that's not how we'd want to market it towards potential users. So we'd like to use higher fidelity parts for that. And potentially, if once we have everything together, we might decide that we'd like to put together all the files or plans or whatever it is and make it possible for other people to reproduce it and use it for themselves. In terms of sort of future goals, so improving the physical prototype. So right now, our prototype doesn't have a brake, which might be problematic. So adding stuff like that. And then also allowing for people who might have a spinal cord injury, for example, who might have issues with grip, modeling and implementing a better handle that will allow them to use the product nonetheless. Also, obviously, this is supposed to be a useful product, so we need to get this sort of usable for patients and get some feedback in terms of like surveys, maybe post use in a focus group sort of setting. And sort of going with that, so getting more feedback and further refining the design so that we can get a final product that people are happy with. And I'd like to end with thank you to the faculty and staff from the Health Design Lab. You guys gave us a lot of resources to use all your tools and giving us your expertise in terms of how to move forward. We also had some members who were part of Jeff Solve, so thank you for all the staff who gave us some expertise back then. We also had McGee Rehabilitation, who had a couple of people who we were able to get firsthand accounts from in terms of the need in this space and in general SKMC. And in terms of disclosures, part of this funding was from the Spring Award and the Levine Award. Yeah, thank you.
I can definitely say that this is a team of makers. They really showed how to learn by doing, by kind of coming in here all summer long, and then after that, building and building and building. And I'm really excited that you found something that works. So you like persisted into this really technical space and found something that actually might be a viable mechanism. So that's cool. But really, I commend you guys for diving into the space of mobility, which is just so opaque and weird. Like the more I learned about, wheelchairs and different accessible devices and how difficult they are to access and how difficult it is to learn about them, it's crazy. So I want to hear from y'all, what was the most surprising thing in your process of inquiry that you learned once you started working with folks like at McGee, for example, and people who use wheelchairs?
I think one of the things that surprised me the most is how limited the average person's knowledge is about what's available. So we kind of expected, given the market share, that most wheelchair users might not know about lever drive systems, but actually several of the PTs and OTs we talked to had never really heard of lever drive pulled wheelchairs. And the first patents for those went on the market in the early 1900s. So the fact that they've existed for so long and really just aren't readily available, even to know about, was very surprising.
The other thing, Saurav already pointed this out, but I kind of want to come back to it, is for any design project, there is a lot of already IP in that field. So we were surprised, having never really seen a lever wheelchair system in person, that there was so much IP out there for it. And it kind of drove our questions of like, why is there so much IP out here for it, but there aren't so many products? Was it a problem with the lever itself? So we kind of wanted to go into like, well, is it actually a mechanical advantage? And then we kind of started thinking it might be a manufacturing and pricing issue that's just exclusive to the regular buyer.
All right, any other question? Do I have a question online?
What actually caused you to go through every redesign cycle? You showed 4 different redesigns in that one diagram. So was it user feedback or some sort of usability? Was it IP related?
So actually, we kind of breezed through that slide a little bit, but we did mention on the slides a little bit of like why we went back and forth to different things. And it was mostly because as we were testing it out ourselves, we found it kind of prohibitive with our own use. So we knew it wasn't going to be the best design option. If you want to talk about that a little more.
Yeah, I mean, that pretty much sums it up. I mean, yeah, for example, pulley mechanism, we were trying to come up with the design that the obviously having a lever is one way to approach this problem, but we're trying to figure out if there's some way to, for example, use the belt as like the way that you drive like you directly pull the belt to drive the wheelchair forward, and potentially that allows you to more easily control like the direction that the arm, like the joints travel in, stuff like that. But eventually, some of the other ideas we had just were a little bit more complex. So the lever ultimately just worked out the best for us.
Any other audience questions? Yeah, go for it.
So I just wanted to know a little more your ideation process on the in situ connections you have for the 3 handle spokes. Because I'm thinking like over time, I'm not sure if those are necessarily made for that type of fatigue and stress, but like, what did you, I obviously can't test for like a long-term thing right now, but like, what did you think about when you were designing that?
And just repeat the question a little bit because the mic is up here.
Sure. Yeah, so the question was, how did we think about sort of the long-term longevity of that connection between those spokes and the hand rim? So the idea basically, I mean, it came from sort of how handcuffs look. So obviously there's nothing, or at least in our knowledge, there's nothing like this that's used for like long-term and like mechanical load-bearing stuff. So we didn't really have anything to base that off of, but just based on what application is being used in, it seemed it would be strong enough for now. Yeah.
And part of the reason we focused on the hand rim specifically is because we were looking for something that could be universal for all style wheelchairs, and like the spokes of different wheels for wheelchairs varies widely and the hub shape varies widely. So existing models that attach to the wheel itself or to the hub have the limitation of they have a narrow sort of area that they'll work with. And in terms of choosing attachment points, we knew that all push rim wheelchairs would have this hand push rim. And given the design of how they're meant to be used, all the force that someone's putting in manually to the hand push rim is being transferred through those spokes. So we knew if it at least had to be strong enough and capable enough to transmit that over the life of the wheelchair, it would probably also be strong enough to transmit the force of the added lever system.
Yeah, we do actually have to test that. Like once we have the model that we're going to go forward with, we'll have to do some sort of use testing to make sure it does hold up, because the hand rim does have multiple points, more than 3, and we're using 3. So hopefully 3 doesn't transfer too much torque in different spaces on the wheel. Yeah.
All right, thank you very much. All right, just another quick break while I transition.
It's still, quit sharing, but it's still good.
I got it.
Okay.
Get better at this every time. Okay, we got that. This. Zoom. All right, I think you got it. Good.
All right, good afternoon, everybody. We are Team 3. I'm Peter, this is Bo, Mika, and Parker. So today we're here to talk to you guys about the effect of visual food models on nutrition education for uninsured Asian immigrant populations. So basically, me and Bo both work at a free weekly health clinic in Chinatown, Philadelphia. The Chinatown clinic is the population is mostly filled with undocumented blue collar workers who have no other access to healthcare outside of our clinic. And so while working at the clinic, we've noticed several challenges regarding like nutritional education with like culturally competent solutions. So there are different like charts and images that exist that we'll talk about, but we want to find a way to create a more tangible understanding for the patients at Chinatown Clinic. So just like a brief anecdote of like one of the real stories that like got us to where we are right now. There was one event, or there was one night where I was seeing a patient with the doctor, and it was a 60-year-old female who had come in, and when we had run her like blood tests, she had come in with, she had like hyperlipidemia, diabetes, hypertension, and when we were just talking to her about her diet, we asked her like what she ate on a regular basis, and she said mostly just like rice, ramen, anything cheap from just the local Chinatown grocery stores. And when we asked her like what if she had ever considered like changing anything in her diet, and she just told us about how hard it was for her to be like working like long hours, like up to like 18, 19 hours a day, barely getting any sleep, and like the concept of like eating food that took longer than 5 minutes to prepare was like just beyond like her understanding at that moment. So yeah.
So yeah, just to give a little bit of context and background for our situation. So we can get this going. So we have 22 million Asian Americans in the United States. This is projected to double by 2060. So this is a very large group that is only going to get bigger. Right now, you have about 120,000 of them are in Philadelphia. And in Philadelphia, you have about 40% of the non-citizen immigrants are uninsured. That's 4 times the rate of the general population. And of that 40%, you have another 40% are the Asian immigrants. In 2020, obesity prevalence in the US was at about 40%. That's just defined as your BMI greater than 30. The annual cost of that, it's usually about $1,800 more per person for an obese person versus a healthy weight. And the obesity rates differ between ethnic groups of Black, Hispanic, and white are usually in the 40% range. But then you go in the Asian percentage and it's only at 16%. So you're like, all right, what's the big deal? Why would you focus on them? Well, aside from the fact that they are a growing population, it's not really the whole story, because a lot of the different, like the WHO and the UK actually use a different benchmark to define obesity for Asian populations. Because these Asians are at higher risk for chronic conditions at a lower BMI, which they set at 27.5. But essentially what that means, though, is that the prevalence of these diseases mirrors populations of other races just at a lower threshold. This is believed to be due to a difference in the visceral versus the cutaneous fat distributions. And then right here, you can just see where the BMI thresholds are. I don't know if anyone in the back can see that, but you guys get the picture. Compared to the native-born cohorts, though, immigrants tend to have a better health when they first come to the United States. But then about 10 to 15 years later, they catch and then even exceed the native-born population. And then the risk of developing obesity, this is really important, is the second and third generations have a 1.6 to 2.3 times higher chance of developing obesity and all of these other chronic conditions. And then specifically for Chinese third generation immigrants, it's a 6 times higher rate of developing obesity. So with all of this said, how does this come into our project at all? Well, the unique immigrants face these different problems. So language deficits, if you have something that is within your native language and also English, you have a better tendency to follow it long term. You have culturally different diets. Everyone eats something different no matter where you are in the world. Food additives in the US have been attributed to increases in obesity. You have social beliefs about health that are strongly ingrained. And then lower socioeconomic status, like we've heard before, is increased rates of chronic conditions. And then all of this essentially just leads to an increased total cost of care because they're ineligible for Medicaid and other insurances. You have an increased risk for these comorbidities, and then you just have an increased healthcare expenditure.
Yeah, so based on all of that information that we searched, we wanted to kind of focus on visual aids and health on managing chronic diseases for the Asian American population. And so, like Parker mentioned, low literacy rates correlate with adverse health outcomes. And although that in Asian American populations and immigrants, the literacy rate itself might not be low in terms of their native language, it can be termed as low just because of the English proficiency. And visual aids have been proven to improve health outcomes in these patients who have low literacy. So that this is something that we wanted to focus on for our project.
So currently, a lot of the models that are out there are limited by like cost, lack of translated health content, and predominantly Western-based foods. So there are some forms of like visual food aid out there, but what we're really trying to target right now is like the immigrant population. Yeah, so these are just some examples of like what we currently have in the clinic. As you can see, they're all just like 2D like pamphlets that are talking about like what you can eat, what you can't eat. Here's an example of like what is obesity and translate directly into like Mandarin. But without like more context, it makes it seem very like abstract to the patient. Additionally, on the left side of the screen, you have the healthy alternatives for food versus less healthy alternatives. But I think for the sake of our patients, we want to make it a more understandable thing in that not only are like some foods like good and some foods bad, but like really understanding like the nutrients behind the food and helping them to understand like why greater quantities of like a good food or like just reducing the intake of less healthy foods, like how that might impact their health.
Yeah, so based on all that information, we decided that our main objective for our project was to create a three-dimensional visual aid item that can be used as an educational material and that can show maybe portion sizes or certain nutritional content of foods that are more applicable and specific to the immigrant Asian populations and that are more culturally relative as well. And so using that, we hoped that, and we thought that it could help these patients understand the nutritional changes that can be made to improve their health. And ultimately, if we wanted to make an objective measurement to lower certain lab values, such as hemoglobin A1C for diabetes and LDLs for hyperlipidemia. So from here on out, these are kind of the next steps we want to take. So currently our target population are the patients from Chinatown Clinic due to access and just for experience, but it can be expanded out to other Asian immigrants in the country. So first, we established a connection with a recently graduated nutritionist who has been volunteering at the clinic, and she has agreed to help us survey commonly eaten foods and snacks within our patient population. And based on that data, we hope to kind of create like maybe 3D print these 3D models, tangible items of portion sizes and other nutritional content of these common food items. And from that on, because we're hoping that these are educational items and educational materials, the dietitian as well as the clinician at our clinics can use these tangible models to help educate the patients. And in the long term, we'll collect kind of a pre and post intervention of the patient lab values of like the hemoglobin and LDL and things that I mentioned, and see if there are any differences and kind of hoping to see effects of the visual aids.
All right, so one of our big takeaways was really how important it is to engage with our communities and to remember that what we've been taught all through medical school is to meet our patients where they're at. And this is one means by which to do so. And by that, I mean to create visuals that are grounded in context, that are relevant to their neighborhood and their cultural background. So the typical plastic food portions or plate sizes aren't what we're going for. We really want to draw from our communities and use various tools in the 3D space to enhance this. Some other things we're looking into to really embed our 3D models with additional information included photo scanning, so we can actually go to these sites, go to these restaurants, scan and upload what our patients are eating. And then there's also opportunities to tag with additional information to 3D models and create visual as well as printed collateral that enhance one another, so that patients that have different learning strengths or modalities can reference back and forth. It's not a one size fits all solution, and I think this is an opportunity to explore this further. And from this, I think we really want to engage with our care teams as well as our patients and create various surveys to evaluate if what we're trying to relate is being relayed effectively. And from that, define a really more intuitive method of communicating between care team and patients. Ultimately, our goal, though, is to really see how that's affecting those long-term biomarkers in terms of chronic illness and progression. And so as already stated, there's obviously substantive gaps in care and knowledge and dissemination of information amongst these populations. We see this as a really viable method, affordable method, and accessible method. All of these tools that we were using, I downloaded and was able to toggle through and explore on my own to integrate into our community clinic settings. And then hopefully we can use what we learned here to expand to other nutritionists, clinicians, and other immigrant population groups.
Thank you.
All right, that was great. Let me just stop sharing real quick and get out of the way. That's awesome. I think this team did a really great job at taking something that's been a challenge forever, right? And that is especially any patient education and communication is challenging, but I'm getting like deja vu. When I was in pharmacy school doing my clinicals at a community-based clinic, I remember doing a presentation like in this exact space, right? Trying to think about how to communicate nutrition information to different populations. It's something that continues to be really challenging. And I love how you guys took the design angle in thinking about, all right, with modern tools and understanding of design and communication, how can we solve that? And especially, kind of think about, well, you need more information, right? So that kind of next step is continuing to get more info about this particular population that you happen to have access to through the Chinatown Clinic, and think about how to kind of bring these spaces together. So that was really great. My question for you is, I really love the idea of 3D printing food models that are culturally unique and specific. Where can you see this going, right? Like if you took this idea to its eventual conclusion, what do you hope for if you did that?
I think big picture wise, other than what we stated in the presentation, I think it can apply to any ethnic group population. So we're currently focusing on Asian immigrants, but it's something that can be used to help nutrition values for every population of the US.
I think as mentioned also, cost is really prohibitive in terms of these different tools. And so to lower that threshold, a lot of the 3D models are on open source platforms, and to so really contribute to the general knowledge, I think would be a major goal and see implemented on a broader scale.
Mm-hmm. Great. Any other questions? Sure, we got an audience question over there. Let's go for it and we'll repeat.
Have you thought about kind of using this in a different use case, kind of to subsidize the cost in the nutritional aspects? So I'm sure that for a lot of toys for kids and whatnot, there's only, the westernized foods as well, and they could use the expansion with these ethnic foods as well, especially with such a diverse country, where you have, these food models and toys of all these different types of foods. Use, the money from that to then also fund this area of, education, nutritional education. Is that something that you would want to explore?
So to repeat, basically the question is, For those who don't have kids, Melissa and Doug is like where all the wooden food toys are basically purchased. Can you get Melissa and Doug to basically finance better nutritional tools, right? Because they're selling really awesome, you know, culturally appropriate toys to kids. What's your thought on that?
I think currently we were more focused on like educational items that can be used by nutritionists and clinicians, just for like resource availability, but it can definitely, I think, expand to, you know, commercial products for kids.
And start the education early.
Yeah.
Right? It doesn't have to just be like a random food thing. It actually could be like an educational item. I got a question online.
Beyond biomarkers, one of our participants was wondering if the visual aids can be used to surface deeper beliefs about food that could lead to additional interventions. In other words, the question is, have you guys considered how you're going to measure potential mindset shifts from your product?
I think surveys, as Mika mentioned, can play a role in that after the intervention. Also, in one of the research papers that we were reading, it was saying that one of the barriers for changes in Asian immigrant diets was the inability to say kind of feel left out or like feel like a burden in social situations if you refuse to eat certain foods. And so maybe our product, like for portion sizes, can help, like, oh, maybe in this one like snack item, there's this much sugar, or this much salt, or like this small amount is the actual serving size that you should eat. So even they can still partake in the social activities, but still have that knowledge of maybe they can reduce a little bit and things like that. So that could be part of the survey.
Sorry. We also discussed potentially having more of a community-based education setting. So having these models in a community setting, cooking together, or seeing if that helps reshape one's thought process around food, and also helps establish support amongst, one's neighborhood.
Sure. You mentioned a number of other factors that contribute, besides just like portion size. Have you thought about how you might include some of those factors into your solution as well?
Like in terms of the food content itself, like nutritional values, fat content, is that what you're referring to?
You also mentioned like, you know, time it takes to prepare the food and things of that nature. Have you thought about how you might include that?
Yeah, actually. So with the 3D models, I think there's so many opportunities to tag and create customized, essentially care plans. Like a nutritionist could theoretically go in and adjust it as needed. And that can include where you would source that ingredient, what the kind of prep time would look, and go about it that way. It could be organized by prep time required.
All right, great. All right, we're gonna keep on rolling. We're gonna keep on rolling. So the next team will be team 4. Where'd it go? All right. Ready to go? Yeah. Take it away. Here you go.
All right, we're team 4. I'm Sam. It's Angela, Eva, and Ava. And our presentation is on a practical approach to prenatal nutrition in low access food areas.
Let's click the notes box.
There we go. So how many of you have ever been to a corner store before? Show of hands. And what are some kind of foods that you would think of being in there typically?
Cheese. Candies.
Figure it out.
All the stuff on that sign.
Yeah. Some of the things on this side, exactly. So
Except not fresh fruit. Surprised by that. Not
this
much.
particular store did.
Yeah,
but-
that's good.
But for the majority of corner stores, you're right. It's not super healthy food. You see a lot of things like ramen, beans, canned goods, stuff like that. lots of like dry grains and other things that you wouldn't consider to be super healthy. But in those, you do have some options that have the potential to be healthy if you kind of doctor it up or change it a little bit, such as like canned fruits, canned vegetables, things like that. So if you're thinking along these lines of you're in a corner store, you're trying to shop for healthy food, now add on like that you're pregnant. How does that impact what you're able to shop for, what you look for in this store? Anyone? Okay, so it makes it a little bit harder is the answer that we were looking for. Pregnancy, a lot of your nutrition guidelines change during pregnancy, and they change pretty significantly. So you have to look out for things like that. And so the unfortunate reality is that you do have a significant proportion of Philadelphians that don't have access to high quality produce stores. In areas of North, West, and South Philadelphia, you have areas where it's significantly low produce stores. So their main means of shopping is going to these corner stores and trying to make do with what they can. And you do have a significant number of patients that are pregnant in these areas. And so they face that pretty difficult problem of how do I shop healthy when my only means of grocery shopping is this corner store? It also disproportionately affects patients of color and patients with ethnicities that are not necessarily white. And that does take into account that a lot of like healthy food is considered not super like culturally diverse. A lot of the diet plans are a lot of food that's like, for lack of a better term, whitewashed. And so it's food that these cultures don't typically consume. And so they're not really going to go out of their way as often to consume it. And so we decided to create recipes that are slightly more culturally competent, because cultural competency and having recipes that you're familiar with and are similar to other recipes in your culture has actually been shown to have an increased adherence to these diet plans. So we did a literature review. We looked at a few different sources of one, not just like what kind of food people like to eat and what kind of seasonings and different spices they have in their homes, but also something that I personally didn't consider until we started doing this was what kind of cooking tools they have in their household. You know, do they have a refrigerator? Are they able to freeze foods and stuff like that? Do they have a can opener? Do they have a blender? One of the things that we found when we were doing this literature review is that a significant proportion of households don't have blenders. Only 61% of people do. That means almost 40% of these households don't have blenders. And so when we were thinking like healthy smoothies, things like that, we kind of had to mix that. So we looked for a cutoff value of over 75%. And this is data from the University of Oklahoma. And so we looked at a cutoff value of over 75%, and then we tailored all of our recipes we made using tools that are found within those homes.
So it's been shown that for populations, pregnant people living in low income, low access food areas, they will have complications, pregnancy complications, such as the ones listed here: gestational diabetes, gestational hypertension, preeclampsia, preterm rupture of membranes, and preterm labor. And so we hypothesized that lack of access to known healthy foods and the absence of healthy eating guides created with foods for people living in FDA classified low income, low access food areas can access contributes to gestational hypertension, gestational diabetes, preeclampsia, preterm rupture of membranes, and preterm labor. We then further hypothesized that culturally competent and readily accessible pregnancy healthy diet plans tailored for people in these areas will be useful to them and also lower the incidence of key poor outcomes.
So to work on this, we set out to speak to a bunch of people in a bunch of different areas to really understand how we could fit into this space. And in speaking to a lot of different members of the OB/GYN team here at Jefferson, we quickly learned that there is not actually an existing standard of care at all to help all patients understand how to change their nutrition when they actually become pregnant, let alone patients like the patients that we're talking about that are living in low income, low access areas, and therefore have an even more challenging food environment than your typical pregnant patient. So one of the people that we talked to is an on-staff dietitian that the OB/GYN department has. However, there's only one, and that's for all of the pregnant patients at Jefferson. There are thousands. So this one dietitian that's on staff only has the capacity to meet with very high risk patients. And so they're only meeting with patients afterwards that maybe already have diabetes. But we wanted to seek an intervention that would be more of a preventative measure. The nurse coordinator we spoke to help us understand what the communication is like between the OB-GYN department and patients now, to figure out how we could fit into that and actually communicate to patients to help them understand what they can and can't eat, what they should and shouldn't eat, and maybe what might be available to them in their neighborhoods. And then for the more technical part of it, we thought we would turn to the OBs. However, after speaking to some of the OBs, we realized what we also were all seeing within our medical education, which is that nutrition is not very heavily emphasized, but these are the people that are seeing every single patient. So the lack of access to the dietitian means that all of the nutritional information that a lot of these patients are getting is coming from the physician, who is not the most comfortable with a lot of the really specific dietary needs of a pregnant patient. They know kind of the big picture, they know the big nutrients, but a lot of the micronutrients they may be less familiar with. So patients are left with this lack of credible knowledge from a credible source about how they should be changing their diet. And that increases a lot of confusion for patients. So to get around this, we decided to collaborate with Masters of Nutrition and Dietetics students. So we partnered with 2 students who helped us create a really detailed micro and macronutrient guide that would meet a nutritionally sound diet for pregnant patients. They included within it some foods that are really high in each of the micronutrients. So taking that, we decided that the best way to get this information out would be to create a publicly accessible website featuring pregnancy healthy recipes and meal plans with ingredients found in just local corner stores and bodegas, also using cooking tools that are found in low-income homes. And some of our goals were that we wanted to allow patients to track their progress towards nutritional goals. We wanted this to be a multilingual website because, as Sam mentioned, a lot of patients living in these areas are not white. They might be Hispanic, they might be Asian, they might be people of color who may not speak English. And we wanted to connect them with other relevant resources as well. However, we did tailor a lot of our recipes towards the Spanish population because we do know that there is a Hispanic clinic, a Latina clinic, excuse me, within Jefferson. However, after speaking to the OBs, they actually thought that this would be useful for all patients. So we will be sending it to a broader audience, but a lot of this is tailored towards that population. So what does this actually look like? Even when you are given a bunch of recipes, a lot of people are not going to know exactly how to put that together to meet those nutritional goals. So we as a group created from our recipes 4 complete daily meal plans that using our recipes, you would be able to meet all of your nutritional goals to help people get started. So you can see that kind of right in the top left picture. And in the bottom, you can see that actually translated in Spanish. We've integrated Google Translate, so it's actually available in over 130 languages. But for this first day, what a patient would eat would be, for breakfast, they could have chilaquiles. For lunch, they could have a chicken tortilla soup. For dinner, they could have a bean burger with roasted corn and onion rings. And then for snacks, they would have a banana, elote dip, and chips. And then a half cup of almonds, whole and unsalted. So if you put all of those together, they would meet the nutrition goals. But as a patient, if I wanted, and then if you click on the actual recipe, on the name of the food, it'll show you the recipe as well as the nutritional facts for that, so the patients don't need to be going to a lot of different sources to find that information. And you'll also notice that within this recipe, all of the ingredients here are things that you can find in a corner store. So you'll see a lot of canned goods, dried goods kind of integrated within the recipe. And in order to generate these recipes, a lot of what we did was source around the internet, try to find the healthy foods that were high in the micronutrients we knew we needed based on our nutrition and dietetic students' plans, and then modify them to include only things that were available in these low-income, low-access areas. And we used a tool called nutritionvalues.org, which pulls values directly from the USDA for what the nutritional elements of all of these different ingredients were to come up with our nutrition facts. But when you have all of these recipes, how can you track how you're doing? And we came up with this daily tracker idea. So this is what is on our website, and it gives instructions for how to use it. But we're going to do a little live demo, hopefully, here. I'm not sure if this will work, but we will see. Okay, great. So when you pull up the nutrition tracker, what you can see is we actually put in almost all of the foods that we had on that first daily meal plan. But you'll notice there's still a couple of red spots here that are the nutrients that we still need a little bit more in. So the only thing that we haven't added from that first daily meal plan is the elote, chips, and dip. And if you add that, you'll see that all of your nutrition values come out. So all of our patients will have access to this. They can add any of the recipes from our menu on here, as well as perhaps source their own. Not sure how to get that.
Good question. Is that for you?
Thank you.
You can figure that out. Stop it. Hold on. I got it.
Well, while Rob's doing this,
Yeah.
I'll give a little bit more information. So all of our recipes are within kind of those orange boxes on the far side. So patients would either be able to see all of them through a drop-down menu or be able to go in and type as well. So hopefully that would be pretty easy for patients to be able to accomplish. Great, thank you, Rob. All right. And then finally, we also included a resource page with some additional resources for pregnant patients, including WIC, which is, and how to apply to that, because that is a way that pregnant patients would be able to have more access to some additional resources, because a large percentage of populations living in low income, low access areas are low income. We did want to provide a little bit of an additional income source for patients that are struggling to pay for healthier groceries.
Okay, so for our next steps, we have divided them up into a few phases. So our next phase, phase one, we are planning to distribute the website, and we're doing this with the help of Jefferson's OB-GYN department. It's going to be sent in through a MyChart message to all of OB-GYN Jeff patients. The message is going to include instructions on how to use the recipe tracker, and it's also going to specify who the intended audience is for this website and tracker, which is our pregnant patients who live in low income, low access food areas. We're also going to use Google Analytics to track return users to the website. We're going to use return users on the website as a proxy for patients who have found it to be useful. In phase two, we're planning on obtaining an IRB. And after that, we want to learn more about our patients' values. We want to find out what's important to them, what they like to eat, how important the other family members that they may feed, cost, all of that, just so that we can tailor our recipes and our website to our specific patients who are enjoying it. In our third phase, we want to expand the cookbook. We're going to continue working with dietetic students and create recipes so that there are tons of options for a diverse range of patients. And finally, we are going to analyze patients who are using the website and living in the low income, low access food areas and compare adverse pregnancy outcomes, their adverse pregnancy outcomes against historical data. And as we talked about earlier, that's gestational hypertension, diabetes, preeclampsia, and so forth. Finally, we'd just like to give a special thanks to many people, including Dr. Livray and all of the Jefferson OB-GYN department, everyone at HDL, Dr. Hayden, Dr. Hutchinson, our mentors, the registered dietitians that we worked with, the dietetic students that we worked with, and the community members who talked about their food shopping preferences with us. Thank you so much. We have no disclosures.
Okay, let me just stop the share. All right, so this is another great concept that kind of builds on some of our experience a couple summers ago. We piloted with a group that was between Esperanza and another group called Sunday Suppers, and it was a super high touch program where we were literally teaching people how to cook. We were giving them food. We were then sending them home with these plans, right, to help them kind of create, you know, these accessible meals that were culturally appropriate. And even in like the short time of this program, we were able to see improvements in a lot of health markers. So it kind of just showed us that when you are addressing kind of, you know, this space in a culturally appropriate way that considers accessibility, it's really powerful. You can do a lot. So it's really great to see y'all take this concept work with our clinicians here and think about bringing it to this patient population. So, you know, a lot of stuff to talk about here. One of my questions for you is, there's like so many great, another great opportunity here between like this world of science, research, and design. Where do you hope to kind of see this in a couple of years as you continue to work on this concept? You have the website, you have recipes, you're working with nutritionists. There's so many aspects of this. Where do you hope to see it as you continue to work on it?
Yeah, so I think one of our big goals is, first of all, to continue expanding this and make it more culturally competent for a lot of the different populations. Like I said, right now we are heavily focused on Latin food, but there are quite a lot of other populations that we think could benefit from this. But the second thing would be to really track, like we said, those outcomes that we know have suffered historically in these populations, and see if this intervention can help improve those.
Awesome. All right, questions, we got one online.
Great topic. So you guys showed us a data tracker, right? The question online is, how do you motivate people to track their food and track what they're eating, as this is a big behavioral shift in itself?
Yeah, so it is a very big behavioral shift. From speaking to the OB-GYN department, it seems like a lot of patients are motivated to make the change. It's just a matter of knowledge of how to do so. So I guess the focus of the project is not necessarily on creating the motivation, as it seems like that already exists. It's more so giving them a means to do so for the motivated patients that exist.
We've got a number of questions popping up in the audience. I will start with this one right here.
I know you're interfacing with the OB/GYN department to find patients, and I was wondering if there's a way through them to also contact patients who are like planning or trying to become pregnant, to try to capture them to start those sort of nutritional interventions early, because we know there are certain, you know, disease processes that would be beneficial.
Let's try to summarize that for the online audience too, that question.
Yeah, so the question was pertaining to how we could maybe target people who are planning to become pregnant as opposed to simply those who are already pregnant. If they are currently seeing the OB-GYN department and there is some kind of tag for that within the system, we absolutely would be able to message them as well and create some separate messaging around that. As long as they're a Jefferson patient, we have access to them through the MyChart system. So that's a great idea for expansion in the future.
Great, and then we'll go to this question here.
Have you considered creating like guiding principles or list of tips, how a person can compose their diet based on what's available, and what to include, what to limit?
Yes, so actually on the additional resources page of our website, we have the complete nutrition and dietetic students guide, including kind of all of those nutritional values and foods that are high within those values to help people kind of tailor their diet in that way. However, we could expand that in the future to include kind of some more robust tips. And like we said, we're continuing to work with the nutrition and dietetic students, so we would lean on them heavily to kind of help create kind of maybe some more broad tips as opposed to specific recipes for people to be able to follow. That's a great idea as well.
And then Mary Beth's got a question in the back.
I guess more comments. So I direct the health communication design program on the Eastwall campus. So project like this is very much in my wheelhouse. I had a few comments for you. So the type of the audience you're talking about, you know, especially lower income, I would strongly recommend you focus more on a mobile platform rather than website. You can certainly have both, but I think your audience is more likely to access on a mobile platform. I also think you could really kind of dig in more to the personalization and customization opportunities within this particular piece, particularly around like developing personal profile. Like I'd love to see you dig into that a little bit more. And I just generally would offer to talk to you about this at another time if you're interested. I'd be happy to help you out some more.
Thank you so much. That's a great offer. We'll definitely take you up on that.
Right, and then for the folks online who probably couldn't hear that, just offering some additional assistance and commenting about how mobile would tend to be a really good way to reach more people versus, you know, just focusing on website, but also website and mobile. This is the last question, right? Yep.
So one of our participants, wanted to ask about, so you sounds like you guys have been in contact with a lot of healthcare providers and getting your product out or your website out there with healthcare providers and in the Jefferson system. Have you guys considered the more commercial route, such as marketing this directly in communities, as well as like those corner shops you've been talking about?
So it's reaching your population directly or community-based versus through the clinic, which is kind of like, seems to be your approach thus far.
Yeah, I think that's a fantastic idea again for expansion. So hopefully after we, within the next couple of weeks, actually get this out to patients and kind of see what the feedback is like, that could definitely be another great avenue for getting people into the program.
Excellent, great work. Thank you. Okay. We're getting there. I feel like I'm getting worse again. Got a couple quick turnarounds. Come on. Nope. You don't want to respond. There we go. Okay. Do that. Notes. And just remember for y'all on this side, if you're gonna present, to come over here because this is the speaker for online.
Is it just the normal arrow to?
Yeah, you can click the button, you can use the arrow, everything should be.
Hi, everyone. Thank you for coming this afternoon. My name's Alana, and we have Yasmin, Noah, Eric, and John with us today. I'm going to be starting off talking about our project, which is determining bystander motivations and hesitations to intervene during an opioid overdose event. So if I can get a show of hands from the audience, how many of you have ever been walking down the streets in Philadelphia and seen somebody laying on the sidewalk seemingly unconscious? Okay. And how many of you have ever wondered, is this person maybe just asleep, or are they under the influence of any opioid and may need help? Okay. And lastly, how many of you have ever actually acted on this thought and gone up to the person or called emergency medical services? Okay.
Significantly fewer people.
Less hands, us too. So this is the exact situation that our team noticed was happening pretty frequently, and what prompted us to take a deeper dive into the literature about opioid overdoses. So to give you some background, opioid overdoses are the leading cause of injury-related death in the United States, and that can be from prescription opioids, heroin, xylazine, fentanyl, among others. And Philadelphia specifically has one of the highest overdose death rates in the country, with 1,171 unintentional opioid overdose deaths reported in 2022, which is the highest number ever reported. And while there have been great strides in harm reduction strategies, like making naloxone or Narcan cost-free and easily accessible, as well as raising public awareness and education, overdose rates do continue to rise. So why? And when we reflected back on our little scenario from before, we wondered, well, what about the bystanders and why are they not intervening? So that prompted us to shift our research to the bystanders, which we found a large gap in the literature surrounding the attitudes and behaviors of bystanders during opioid overdoses. And so we went to the public on a more general sense, to Twitter, or now X, excuse me, to kind of gauge public perception of this issue. And we highlighted a few up here. For instance, somebody posted, just Narcan, my first person since being in Philadelphia. About 15 people walked by despite being purple. Wild how we have all lost humanity. bystander effect is real. So this just showed us that this is a problem beyond the literature and beyond a reported statistic. It's a problem that's even creeping into the public eye on social media. So all this information together, we created our problem statement to guide our research, which is how might we understand bystander perspectives in witnessing active overdoses? Because the factors that motivate or deter individuals from intervening are unknown.
So just as Alana alluded to, we wanted to, based off of previous literature, we wanted to understand the relationship of certain, characteristics, as well as experiences that might affect someone's ability to intervene. And we hypothesized that previous exposure or personal exposure to overdose would impact an individual's motivation to intervene in an overdose. And we also hypothesized that fear will be a significant driver to deter bystanders from intervening, maybe through like fear of physical retaliation, worry of causing further harm and retribution. But these are just some of just some ideas that we were thinking of based off of what we've understood from other papers. And this is a very busy slide, but we were only able to find a couple of papers, but some of them actually gave us a lot of really interesting information with regarding to bystanders intervening in an overdose. And in one paper in particular, where they actually, through a retrospective survey, they interviewed people who had already witnessed an overdose before to see how many would actually call 911. About 70% did. And they found that actually in a majority of cases, respondents reported that there were bystanders there, or more bystanders there that had witnessed an overdose, and were actually twice as likely to call 911. However, if you had experienced an overdose before, it seemed to have like a lower effect, like people seemed to be less likely to call 911, and they attribute that maybe to the fact that they felt like they'd be more likely to resuscitate the individual, or they're more comfortable doing that. Interestingly, gender seemed to have an effect as well, that women were more likely to call 911 in that sort of situation. But similarly, they found that studies, even until the previous studies from 2005, so a long time ago, but even recent studies that have looked at this have found that calling 911 as a way to potentially help someone, there still was a fear of being arrested in that situation, even with the advent of Good Samaritan laws. So our study wants to look at the motivation of bystanders who may or may not have witnessed an overdose, sort of broadening the group of people we would be interested in talking to, and see how certain characters would affect some of the questions we ask.
So this slide's a little bit of a recap of what people that Yasmin and Alana have already discussed, but we wanted to kind of lay out our process with coming up with this survey, just to kind of give you an overview. So first of all, we were kind of posed with the question of health equity and how can we address an issue of health equity in the city of Philadelphia. And then we started to think about, as med students, what do we see in our daily lives around Philadelphia and where can we really make an impact? And that kind of led us to this idea of attempting to address the opioid crisis in some way. The next step was, will we build an actual physical device that could perhaps detect an overdose? We briefly thought about that, but instead we kind of shifted our focus to more understanding the motivations behind bystanders, because we thought it was a more feasible way of addressing the issue right now, and perhaps we can explore more of a physical device down the road. And then we looked into the literature, and as Yasmin just discussed, there's obviously some literature that's proven that there's a gap in understanding between bystanders that's perhaps holding them back from intervening and making a larger impact and lowering the horrifying statistics of overdoses. And specifically, there hasn't been much research that we found in the city of Philadelphia. So it was even more of a motivation for us to say, how can we use this survey specifically in Philadelphia, make kind of even more focus our goal to focus on addressing the problem here in Philadelphia. And then finally, the result was to come up with the survey. So we built our survey in Qualtrics, and we adapted our questions kind of from existing literature from the paper that Yasmin talked about, and we added some of our own questions in. Essentially, like I said, we wanted to assess the motivations for bystanders passing opioid overdoses and what may or may not be holding them back from intervening. And our inclusion criteria was to look for consenting adults over the age of 18. And then once we gather this data, I think we will run some statistical analysis on this using t-test, and we can also run some regression analysis. But essentially, we want to try to determine the individual level correlates associated with increasing the odds of intervening, and try to elucidate what is correlated with increasing or decreasing the odds of intervening. And then we do acknowledge that there are some biases just inherent to collecting this data through our surveys. There's response bias, and also there's going to be bias with regards to who exactly we're distributing the survey to, considering that we are medical students, and some of the people that we will hope to be surveying will be other medical students and medical professionals, especially in the city of Philadelphia.
So as we were talking about with our project form, which is right now in survey, we're currently awaiting IRB approval. We're going for exempt status, and we're just fine tuning a couple stipulations, which should be they should be receiving those very soon. And then we're ready to distribute the survey throughout Philadelphia through listservs. We have QR code. Be distributed through the Jefferson institutional email address for legitimacy. And to talk a little bit about the survey, the kind of things that we're really looking at here, we'd like to know about some demographics, personal exposure to overdoses or opioids, whether they feel comfortable or able to recognize overdose signs, some of their attitudes towards people who use opioids, their general knowledge about opioid treatments or first aid efforts, and also their fears regarding this. These main points came about because prior surveys that have been done and also research in this space, they've brought up a lot of these as potential reasons as to why people have been probably hypothesizing for a while, why would someone not want to help in an emergency. And we're still here today, and the problem is still getting worse because the answer is not clear. If the answer was clear, there would be much clearer guidance on how to move forward. So this is another step that we're taking to add to this this field, because everyone's searching for an answer, and that's what we're trying to do as well. So hopefully our input, which would be our data from the survey, hopefully elucidate obstacles that bystanders face, as we had mentioned before. And so some of the things that we're trying to see, as we've mentioned before, is there any clear things that are showing what might impact someone's ability or willingness to intervene? Some common trends that that have been maybe hypothesized to deter someone or motivate someone. Maybe their ability to know that an overdose is even occurring. You can't respond to something if you don't know that something's wrong. So that could be a major thing, because a lot of as we mentioned in the beginning of our presentation, a lot of the efforts have been on making Narcan widely available and very cheap. I don't even think you have to pay for it at the pharmacy. But then also overdose education programs and getting people educated on this. And if people are still responding that I don't know how to recognize an overdose, well, then that would be a major gap that could be addressed, and so on with some of these other things like administering Narcan. If you're doing trainings and maybe they're not as effective, willingness to call 911. We address some of the things with bystander effect. Is that still with Good Samaritan laws, because those were passed relatively recently, so maybe people aren't even familiar of what those are, and so on and so on. And also in bold, we have here the impact of previous opioid exposure, if that is really a driving factor.
Great. So at the end of this, the conclusions that we hope to get are just a better understanding of different relationships that relate to the demographics that are walking on the street and whether or not they're likely to intervene. So does exposure to opioid use impact one, likelihood of recognizing an event? So the more exposure, are they more likely or to be better equipped in recognizing an overdose? Likelihood of intervening? Are people that are exposed more likely to be inclined to call 911 or administer Narcan? Are they more likely to help despite feeling inadequate? So even if they don't know what to do or how to help, is someone that is exposed more to these overdoses, are they more likely to do something? And then helping despite feeling unsafe. So these are all things that we've looked at. If someone is feeling unsafe, does exposure lead to a greater likelihood of wanting to, help despite having that feeling? These are going to be what our primary objectives are. And then if we look into secondary conclusions, there are other factors like gender and age of opioid drug users and an impact on the likeliness to intervene. So if a bystander is walking on the street and they see someone that is a similar age and a similar race, is that something that's going to affect whether or not they want to intervene or not? So these are all things that we're aiming to do to characterize what makes a bystander tick, what makes you want to help, and what makes you feel that empathetic drive towards that person on the street to really help them and want to, save them. So our ultimate goal is to utilize these survey findings to create targeted interventions and thus decrease fatal opioid overdoses in Philadelphia. And this is going to be through things like targeted educational resources, apps that help, group together different bystanders. It could be devices. There's so many things that you can do once you have a better idea of who you're trying to target. So just a quick future roadmap. We're going to have 4 prongs here, really: disseminate, analyze, publish, and present. So the goal is to disseminate this survey to the people walking around in Philly, your average Joes, me and you, anyone that's going to be coming across people that are overdosing. Next is to then analyze the data and get a good understanding of what the factors are that we need to focus on, publish commentary, and then present these findings to the public. Hopefully work with different public health agencies and other companies, whether that be private or public, to kind of create a greater impact. And we just want to thank everyone that's helped us through this. We could not have done this without all the help and support we've gotten. Thank you.
Hey. Awesome. Great work. I think, you'd have to be living under a rock to not see that this is a really important space, and that, more information, more solutions, pretty much like just so much that's needed in this space to move the needle forward. And I commend this team for kind of diving into this issue and really just recognizing that there is a need for more information. Right, this is the space that a lot of people are trying to dive right into solutions across the board. Whether we're talking about different tools to bring more access to things like Narcan and other different solutions, but really the fact that you recognize that the thing that needs to happen here is we need to learn more. And it's clear that you found this through your direct inquiry. I want to point to a comment online from one of our enterprise leaders. Offering an opportunity for you to attend one of the upcoming Jefferson opiate task force meetings, because that's a really great opportunity there to both learn and potentially find other supporters who can kind of help you with this project moving forward. So that's really great to hear. I always love seeing how you've found some supporters thus far up until this point. Now you're kind of even gaining more and more support as you continue to talk about this and learn more about it. My question for you is, I know, kind of you've grappled a lot with what is the right population, who you're going to survey. I really look forward to seeing, what are your thoughts on how are you gonna get this out, get the survey tool, right? That you gotta find people to do it, to actually take the survey and learn from them, and then you gotta take those results and get them out to the world, right? So what have you put into both of those buckets, you know? How are you gonna get this survey into the hands of people so you can get the most amount of information as possible from the types of folks that you want to hear from? And then once you have that, what is your thoughts about getting the word out? And then I'll just make one more comment about how I think we've all heard we've got a new mayor in Philadelphia, and one of the first things she announced, right, was that we need to do more in the city about, you know, some of the challenges around drug use disorder and you know, the terrible things that are happening to families here in Philadelphia around it. So what are your thoughts there?
Yeah, that's a great question. I think the one main thing about, you know, getting the survey out and disseminating is we need to make sure that we're getting a wide group of people. We can't just reach out to med students in our direct network, because we're all med students and we're all going to say we want to help and do the most that we can. But is this the same thing for someone that's working at a bank, or is this the same for someone that's working, you know, in consulting? So getting everyone that has different exposures to their level of ability to intervene is something that we want to capture. Everyone has different knowledge of what you know, what an opioid looks like. So in order to do that, we need to get a wide range of, you know, who you are. So in terms of disseminating, we can go through institutions first. We could start with Jefferson, and then we would also reach out to other companies around Philadelphia to send out their surveys to their employees. And that's kind of, you know, a channeled network we can go through. And then aside from that, you know, there's 5 of us right now, and we could definitely recruit some more people to just stand outside on the streets in Philadelphia and do some convenience sampling. It's a quick survey. There's QR codes, there's written forms. Getting the people who are actually walking day to day on the streets, that's going to give us a really good result.
Right, so it sounds like currently the goal is to cast a wide net.
Yeah.
Exactly. We want the data to speak for itself. We don't want to make any assumptions because there is this lack of data of what people's motivations are. We don't want to even necessarily assume that someone who's a medical student, you know, would absolutely guaranteed help the person on the street, because, you know, we've all walked past people, and then we don't want to make assumptions. We want to let just all the data come in.
I think just to add to that point too, I think the idea too is to disseminate this as well, like outside of institutions, because it's not going to be people, not always going to be people who are, you know, have a job or whatnot. But we were thinking of going to train stations or areas where like just general people who are just walking around and, you know, just having sort of a station there. And I think actually Alana knows of like a group that is like kind of a pop-up, I forget what the name is. It's called the Everywhere Project. Yeah. Yeah, and so essentially those might be great opportunities for us to interact more with even individuals who may have more personal experience with opioid use disorder. Okay.
Right, we got a little time, maybe a couple audience questions, sure, from here.
I have a couple, but I'm gonna
Mhm.
try to come all together.
Go for
So
it.
following up on this idea of your target population, so kind of 2 things. I think you've got one population you're gonna need to reach out to kind of get an initial survey, you know, which you guys are already talking about. But I guess the population that we want to target then to better educate and train. You know, I think that might be a different population, because you want to be a little bit more narrowly focused, because otherwise you're never going to be able to get anything done. And I would kind of mention to you to think a little bit about that, because, you know, Philadelphia, you have visitors from out of town coming in, you know, people like me who I live way out in the suburbs, and I drive into here just for my job. And that also kind of plays into the idea of the fears that people have towards actually interacting with a person that they might see on the ground. I don't have access to Narcan where I live, you know, I don't know that I would be able to get that. And secondly, you know, how do you recognize those things? You know, that is always something that I came to. Is it really somebody that's overdosing, or is it literally somebody taking a nap? You know. So that might, you know, the population that you target to educate might be slightly impacted by, you know, the biases or fears or whatever, where they're also coming from. So as you think about moving forward, that kind of think about where you want to go, and that'll kind of dictate, you know, what you might have looking at. But do you have any comments on that? I mean, do you have an idea of what population you want to actually try to target?
Say to cast the broadest net,
Yeah, I
to
think
see if there's any trends that come from the data, and then whether it's subsequent surveys that are more targeted towards certain populations of people, I think that would probably be better, because then otherwise, it's hard to know where to start based on like the literature that's out there, because then anybody can really be a bystander. So I feel like it'd be more difficult to arbitrarily just decide that one group is more likely to walk on the street and see someone in another group.
And there's no question that, that obviously, like, as you pointed out, that Philadelphia, you have visitors, you have people from out of town, things like that, but it goes back to like casting, initially, I think it's best to cast a broad net, collect some data, and then ultimately, the population we're trying to actually educate most likely would be like residents of Philadelphia who are actually in a position to intervene with opioid overdoses. The odds of you coming across someone who's overdosing is probably far lower, but I think hopefully we can, at that stage, kind of tailor our approach to hopefully target people who live in the area, but initially try to start broad.
And also just to note that intervening does not mean that you need to have Narcan and to revive someone. Intervening can be as simple as just calling 911 and getting, emergency help so that they can, save the person. So that could be a myth that might need to be dispelled in the community if people feel that it's, really involved to save someone's life. Like I have to do all this stuff and I don't know what to do. It could be as simple as calling 911, and that could make the difference.
Thanks for the comment, buddy. Sorry. Some more back there. Go for it, yeah.
Well, I think this is a really wonderful topic. Again, it's just more of a comment and an offer. The students in my program last semester just finished partnering with a group of Pew researchers, and we created a really massive report mapping the opioid use disorder treatment system in Philadelphia using GIS mapping. I can just send you the report. It might include.
I immediately sent them that report as soon as it came out.
You have it.
Oh,
Yes.
absolutely. Yes, like as soon as that thing hit, I was like, you all need to read this. Yeah. And then there was one more comment, then we gotta move on after that.
I was just gonna say, thank you for sending that report. We did give it a read, so that was really great.
Yeah, and for the folks online, that is a report that came out of the, I don't wanna say your program's name wrong, so can you remind me, Mary Beth?
Health communication design.
Yeah, the Health Communication Design Program here at Jefferson released a really fantastic report in kind of relation to the experience of somebody who's going through recovery. I encourage everybody to read it. It's really awesome. We're very well designed, I say.
I just wanted to piggyback off the population definition question. I know you said initially you're gonna do a bivariate regression, but I feel like if you want to define like a more granular population range of who you want to target, there's gonna be a lot more codependency. So I'm wondering if you're gonna consider like in the next steps, like multivariate.
Yeah, absolutely.
Okay.
So yes, thank you.
Yes.
All right, great. Thank you. All right, we have our last team coming up. And thank you for everybody who is hanging in with us still online. We see you. You're doing awesome. Sarah was just gonna type that, but I said it. Nope, just that shortcut doesn't work anymore. There we go. All right. Yeah.
Alrighty, hello everyone. My name is Adora. I'm here with Sandy, Stephen, and Matt. We're here to talk to you about our project, Increasing Awareness of Postpartum Risks through an SMS text-based educational tool. This project was inspired by the stats around pregnancy-related mortality in the US, which we all know is a pretty significant problem. The rates in the US is 3 times higher than almost any other developed nation, and it continues to rise every year. Racial inequities are a major driver of these stats, and pregnancy-related morbidity and mortality continues to disproportionately impact non-Hispanic, Black, and Hispanic individuals. Specifically in the city, there's a higher rate of pregnancy-related deaths compared to the national average. In a recent report surveying the city, looking at different stats regarding pregnancy-related deaths, it was found that 54% are preventable, and then 32% of these result from late or no prenatal care. Another interesting finding from this report was that a large portion of pregnancy-related deaths occur in the postpartum period. And just to highlight what that could mean in terms of time, it can span from anywhere between 0 to 1 days up until the following year. We kind of just use these stats to inform what we're trying to look at for our project. We are looking in the digital health space in terms of tools that can be developed for pregnant patients. So here are some of the pre-existing digital health tools that are out there. Overall, access to smartphones has been increasing over the years in low-income communities as well as communities of color, and digital tools are becoming a more accessible way to gather health data, as well as offer up educational content, as well as like additional ways to connect to medical care. So one of these tools that are out there is this text-based blood pressure reporting service that allows patients to report blood pressure directly to their provider. It was found that folks using this program were able to report more blood pressure measurements 10 days postpartum compared to folks who are going into a doctor's office to collect those measurements. Some of the gaps in a tool like this is that it's only focused on one aspect of postpartum health. Looking at another app, the WY Health Due Date Plus app provides educational content. Usage of this app was associated with higher rates of prenatal visit completion and also lower rates of low birth weight. And then some of the gaps with a program like this would be that it's focusing exclusively on prenatal health. And then another big program that is out there is the Text for Baby. It's like a text line that provides both educational content and also just reminders about things that you might need to do in the prenatal period. So this just involves texting the word baby to an existing phone number. And then this has been demonstrated to be effective, especially in low-income communities. And one of the gaps we identified with this app or this tool is that it's only focused on postpartum content related to the baby's health and doesn't really discuss particular risk factors when it comes to the person who just delivered the baby.
All right, so moving into defining our problem that we were trying to address with our project, we decided that there's a need for an easy-to-use and accessible tool for pregnant patients to help identify signs of postpartum complications and provide education about postpartum warning signs earlier on in the pregnancy. So before the baby is actually delivered, kind of just having a preview of that while you have maybe more mental space or time to think about it. Okay. And so moving into what our inquiry question and hypothesis were, so we were wondering how we could develop an educational tool that could empower patients with knowledge about their prenatal care and postnatal health outcomes. And so we decided our hypothesis was that an SMS text-based educational tool that periodically educates patients on post-birth warning signs and complications and follows up to ensure patient awareness. So sending messages at multiple time points throughout their pregnancy and after would improve their knowledge of postpartum health and allow them to more effectively contact health resources when that is needed. So being able to identify those risks and also know who or what to reach out to.
Okay, so moving into what we did and the methods we used. So we decided that our target population would primarily be pregnant and postpartum folks within the Jefferson Health Network, and also the support system for that pregnant person, whether that's loved ones or anyone else caring for them. And we particularly wanted to reach out to vulnerable populations. As Adora mentioned earlier, there's pretty similar mobile phone ownership across different racial and ethnic groups, and a lot of low-income families actually only have a cell phone and don't have access to like a fixed phone line. And so this was a great way to be able to reach people of a wide social, economic, and racial range. And so moving into data collection, so we looked into existing data. So we did a quick literature review, saw what kind of surveys were available both to the public and also to healthcare providers. We also partnered with Dr. Liveright, who is an OB, and Savannah Galloway, who is a manager of quality and safety at Jefferson's OBGYN clinic, just speaking to them and understanding what their understanding of their patient needs were. The clinic they work for also provides services for the Latino Women's Clinic, so they have access to a lot of women who maybe are of lower social economic status, or maybe don't have, or maybe of uninsured status. Yeah. And so the other thing we did was we actually also subscribed to Test for Baby, which is a pretty similar service to what we were envisioning. And through that, we were able to see that basically most of the information was about the baby and not necessarily about the pregnant person's health themselves. And then we were working with an existing educational resource that is currently being handed out by Jefferson OBGYN Clinic. It's this acronym post-birth, which gives a pretty straightforward way of identifying potential risk factors and warning signs following pregnancy. And we just wanted a way to be able to distribute that in a more effective and accessible manner. Yeah.
Right, so to continue with our methods a little bit, so moving forward, we're planning on utilizing this tool, and we really want to collect data on user self-assessment and knowledge. So whether patients, as a result of taking our survey, are more aware and more knowledgeable about warning signs to look out for, not only what warning signs to look out for, but how to act if they have any of those warning signs post-birth. And then we also want to look at the number of patients who are actually completing the survey. So we want to look at basically the rates of completion, or within the survey, how many questions patients are actually going through. So to see what information they're actually being fed through the survey, whether it be part of it or all of it. And we're pretty confident that through our survey, patients will see an increase in the confidence in their own abilities to identify postpartum complications. And again, we're going to assess this through user feedback at the end of the survey, essentially asking about satisfaction and also awareness of these warning signs using a predetermined scale in the survey. And then, so I really want to dive into exactly what our tool is and sort of the platform it's going to be used on. So we are using REDCap, specifically a component of REDCap called Twilio, which allows you to send SMS messages out to patients. And so we're going to enroll patients through MyChart through a collaboration with the Jefferson OBGYN clinic, like we talked about. So essentially through MyChart, patients will be able to scan a QR code or click on a link that will enroll them into the survey, and at which point they'll be sent a text at specific times during their pregnancy. Ideally, some point in the before birth process, and then they'll be sent some reminder texts in case they still haven't filled out the survey as they're approaching their birth. And like we mentioned, our product is really based on an existing post-birth educational poster that the Jefferson OBGYN clinic usually currently uses. But the idea is that we're going to take the key components of this poster, sort of the highest yield warning signs, and add educational elements to them. So essentially, if a patient enrolls into the survey, they'll receive a message that gives them a basic description of what it is that the survey is, and then they can press any key to continue. And so the warning signs that we're going through, there are a number of them, but the word post-birth, each letter corresponds to one of the warning signs that we're looking at. So for instance, P stands for pain in chest. So the patient will get a message that says that P stands for pain in the chest, which means you could have a blood clot in your lung or a heart problem.
Even if you've never had one before, pregnancy can increase your risk of having a clot, which blocks your blood flow. If you have chest pain after you give birth, call 911 or seek immediate medical attention. So that's the educational component that they would receive. And then to continue with the survey, they would be prompted to text the word pain. So that also then provides the patient with an immediate sort of interactive way of, just quick one-word pain. So they can remember what warning sign to potentially look out for. And they would go through all the other warning signs in our survey. And then, yeah. Okay, sorry, one more slide here. So essentially, like I said, patients are going to be approached and enrolled through the OBGYN clinic, specifically through their MyChart during the prenatal period. And then we're planning on issuing 3 rounds of messages to try to increase user usage of the platform. So in the second trimester, essentially at the time that they're receiving numerous services through the OBGYN clinic, also in the mid-3rd trimester, and then one more time following birth if they still have not completed the survey. Like I already mentioned, satisfaction and comprehension will be assessed. Comprehension is going to be assessed pre-survey, and then again after survey, and then also satisfaction at the end of survey. And we're also going to look at responder retention, number of patients who are actually using the survey.
So as for the results, we don't have them yet because we have still not yet implemented this, but based on what we were talking about with Dr. Liveway and Savannah, her nurse who helps her, we do know that there is a lack of access to digital health resources, especially in underserved areas, and we think something like this would be able to address that need. What we've been working on so far is that we've been reducing the scope of our project progressively so that we have something that's more implementable in the time frame, especially considering with anything health related, we need to make sure that we cover enough contingencies that we address people's needs, but not so much that we leave the risk of them misinterpreting what we're saying and potentially taking the wrong course of action. We're also trying to improve the accessibility of the language, something that we as physicians, or when we will be physicians, we have to be aware of is that we have to use a lot of medical jargon, and especially for people who might just be, say, English as their second language, we need to make sure that all the education that we provide is easy to understand for all levels of English. And hopefully, if we can implement an education earlier into postpartum period, it will help reduce the number of preventable complications that occur. So currently, we're still working on our draft for REDCap, and then we'll be trying to implement the survey with revisions in our iterations. And then we'll be streamlining the questions down to what we believe are the most important, or the things that have the highest rate of a serious complication to reduce the amount of questions that someone needs to answer. And then we'll get the results based on surveys that we'll provide after they've used our tool. So some of the limitations, although we can educate patients for better or for worse, there's still a lot of systemic obstacles that patients will need to go through. One of the ways that we're trying to get around this, though, is that Dr. Liveway has spoken about having a way to streamline the communication between the patient's education and the provider. That way the provider is up to date more on kinds of education and implementations that we're giving to the patients. So there's less redundancy and a faster time to action. Some of the other things that we have to work around is experimenting with REDCap itself and Twilio, figuring out a way to distribute this widely to the community, addressing a large range of complications. And hopefully we'll be able to implement this, get the text bot and get our feedback quickly. And then hopefully expand our scope to include other languages, and similarly addressing other kinds of educational content for other areas. So I'd like to thank Dr. Livewright and Savannah, Dr. Kelly for being our advisor, Rob, for running the design lab and giving us advice throughout this entire journey, and then everyone else whom we've worked with. So thank you.
Okay. All right, great work. I really commend this team in particular for again tackling a problem that is really big, really complex, and is, you know, something that we all kind of hopefully are aware of, just like the atrocious disparity in maternal and health, especially in this city, right? Where you know, the city where there's so many disparities in the city, and then the maternal mortality and infant mortality in the city is really just terrible. There's a lot of work that needs to be done. And I really love how you are kind of looking at it through this design lens. And you can, and with your kind of powers of design, can think about, all right, how can we get better communication to people when they need it so that they understand it better, again, to hopefully try to move the needle in the right direction in a population that no matter what, so many millions of dollars are being spent and so much, you know, despite the fact that it's hard to get resources to where there are resources, right? But they're just not getting to the people who need them. And that's the perfect problem for design to potentially solve. So great work in that sense. My question for you is, you know, as you are looking at the problem, right, and you have some great mentors and some great clinical kind of folks who are helping you in this, how did you begin to think about the solution, right? This, like, and the form it would take in terms of, you know, right now, I think you're looking at text-based solutions. And how did you get to this idea where, you know, you are designing a solution that gets information to somebody at the right time? What was like the kind of the moment for you there that made that become your understanding?
So initially we would have pretty broad scope. We actually didn't know if we didn't know if we wanted to address
Specifically postpartum or prepartum, et cetera. And like our initial thought was actually to make like a purely community intervention and put like QR codes out with the survey for people to be able to take that and like learn a little bit about what their risks might be, both like pre and postpartum. We ended up moving more into postpartum period just because, as we explained, like we began to understand that a lot of resources were already available on the other end. And then regarding like, I guess, sending repeated messages, it was what we kind of mentioned earlier too, where we were saying that although like people will have a lot of information available in the postpartum period, it might be nice to get it to them a little bit earlier when they maybe have more mental space to think about it, instead of just kind of having a ton of information about their baby, about, you know, figuring out having a baby at home now and everything. You know, after that happened, like then getting all information. So we wanted to get the information from earlier. And the iteration was just because, yeah, like you take it once in like second trimester, maybe you're going to forget about it. And so we want to at least have like another sort of reminder closer to the actual birth date. So once the complications could potentially arise, they would be able to hear the information again. So yeah, and we're still trying to figure that out. I think like we have some thoughts about sending a simpler survey later on, or just something with like just the picture of the post-birth complications, just so that they'd be able to see it again and keep it in mind. So sort of like spaced repetition in some way. Yeah.
Awesome. Other comments or questions from the audience? Go ahead.
Well, I just really want to commend you. I think it's a really smart strategy. If I have a suggestion, it would be maybe another step you might add is kind of a food survey that's patient focused, that asks them maybe some of their preferences, so you can really have the most beneficial user experience as possible. For example, a question you might ask is like, what time of day would you like to be texted? If this text reaches them when they're very busy, you know, they're not even going to read it. So a simple question like that.
That's great.
Yeah.
Sorry, do you want to respond to that? Or that's good comment?
Oh, no, I was just gonna say, yeah, that's super helpful, because one of the things that we're really sort of, I guess, most weary of is, yeah, that user retention and making sure that what we send out to patients is actually getting a response. So we can optimize, yeah, the timing of the day based on when patients are more likely to, yeah, fill out the survey. That would be great.
And there was another comment behind you?
Yeah, on that the product adjacent to this new the weight loss platform that probably so everybody's Instagram 25 times or more. they use this very effectively, and will ask the prompting questions, so maybe that experiment.
And for the folks online, the comment there was a great analogous product is Noom in the way it provides information kind of when you need it in short, kind of period, short blasts. Any comments online? Nothing online. Anybody else here in house before we wrap for the day? All right, great job. Okay, so we already gave another round of applause, but I want to say great job to all of our teams. I think the thing that I want to point out is that everybody chose to try to tackle really hard problems, right? There's no easy problems that anybody's trying to solve, and as you can see, because of that, these are all works in progress, right? These are challenging things to try to move the needle on. So for the folks in the audience or for the folks online, if you have ideas, if you have comments, or you have maybe resources or want to offer some help, please do reach out to me. Sarah can drop my email. It's robert.puglisi@jefferson.edu. You can also go online and you can find our contact form at healthdesignlab.com if you want to reach out and offer some help to these teams. One of the things that's really fascinating to me is that there's so many different spaces that our students are working in, both in this year, kind of the year that you just saw, the year that's coming up. Our first year medical students are just trying to figure out what problems to solve. And that's the breadth of problems. We've got folks working in engineering and solving these mechanical kind of human problems. We've got problems that are public health facing. We've got all these different things. And the thing that brings them all together, what is the kind of stuff that knits all of these problems, and that is design, right? The idea that and that is kind of our hypothesis here in the Health Design Lab and through the SI Design program, that's through better design, right? We can have not just better solutions, but a better understanding of what people need. And I think that's the really good stuff, right? Ultimately, that's why our students kind of come into this program, because they see that a lot of people are throwing things at the wall. And the thing that usually makes the difference between how valuable something is and the real effect is how well are they designed, right? How well do the folks who are trying to solve these challenges, or how well are they listening to the folks who have the problems and listening to them throughout the process and collaborating with them. So thank you to all of our students in this program who take that to heart and are really trying to challenge yourselves to look at things differently. I think it's a hard thing. It's not the easy path by any means, right? This is the harder path that you're choosing to take. And it's awesome, and it's really awesome. So I want to congratulate you on choosing that. And again, I'll thank everybody who I thanked earlier in the class or earlier in the session for enabling this program to exist, for enabling the students to do what they do. And on that, I'll just wrap with I don't have a good quote, but I'll just say we were all very inspired today, I think enough, and thank you all for joining us, and thank you for being here. Oh, and we have, for the folks who are here, sorry, we can't give you anything online. We've got some snacks and desserts on the back table. There's coffee and seltzer in the break room. Please hang out and chat and talk. To our students, don't be a stranger. We're here, even though you're going to be on clinicals and you're going to immediately forget about us as soon as you start studying for your tests. Don't come back to us and come and keep working on your projects. Thank you.